Hello, everyone. Welcome to today's webinar. I hope everybody can hear me okay. As we were preparing for this, we joked that if it doesn't go well, then that also reflects on telehealth as a thing. So I'll say I did it on purpose no matter what happens. So thank you for being here. This is a webinar on telebehavioral health and healthcare for the homeless. I'm Michael Durham, and I will be your moderator for the webinar, which is presented by the National Healthcare for the Homeless Council with support from the Health Resources and Services Administration. This is a 1-hour webinar with the bulk of the time dedicated to discussion. Please actively use the chat box below the presentation slides to interact with the panel. You may also raise technical issues in the same chat box or by calling the main office at 615-226-2292, extension 241. And that's Cecilia you'll be asking for. This webinar is being recorded and will be archived with the presentation materials at our website, nhchc.org, the week of October 7th. So let's start our discussion with why we're here, and just sort of to frame what we're going to talk about later on. So the council launched a project last year that we cleverly called ITIP, Idea to Implementation Project. And the idea of this was to kind of bridge our conference with our ongoing technical assistance. The idea was you come to our conference every year, you get really inspired, you attend one of Brandon Cook's workshops, and you learn about telehealth, and you're really excited to do that at your own program. But then you return home and emails abound, and there are staff crises, and there are a lot of reasons why you don't actually do what you set out to do when you had that inspiration at our conference. And so we set out a call for applications and to really just provide some more in-depth technical assistance and hand-holding to get folks to actually make it happen at their own organization. The project we worked with was in Florida, a healthcare for the homeless program that wanted to launch telebehavioral health. In this process of this, just really mentoring this program along the way over the course of a year, we encountered lots of challenges. Some of them may be specific to the program in Florida, but others we think are really universal. And so one of the things we wanted to do just in learning from this process was open it to the whole country. Let's have a conversation about why telehealth can be difficult technologically as it relates to staff and hierarchy and lots of different challenges. And let's bring together some experts from across the country, all of them have different structures of their health center and different degrees to which they're using telemedicine. So that's what we're going to do today, and we're really going to be learning a lot from you all too. We set this up to be heavily discussion-oriented, and we're going to be guided by 5 folks from 4 programs across the country, as I said. A couple things that I want to just mention as caveats is we know that regulations in telehealth really differ by state, and we're just not really going to get into that. There are telehealth resource centers across the country that can answer some of those regional or state-specific questions, but that's not really going to be the scope of what we're doing today. And then we're also not really talking about like remote medical consulting. I think of like Project Echo, where like a provider is using telemedicine sort of software to consult with a specialist. So that's not really what we're talking about. It's like we're using technology to see patients in the field or at the clinic, wherever. So let me introduce our panelists, and then let's go from there. So we're really excited about the group we've assembled. We've got Lee Thornhill in Seattle with the Healthcare for the Homeless Network of Seattle-King County. Debbie Stevens is with Mercy Care in Atlanta, one of my favorite programs. Brandon Cook and Jennifer Schmucker are with New Horizon Family Health Centers in Greenville, South Carolina. And Andy Roby is with Unity Healthcare here in Washington, D.C. So I'm really excited for each of these folks to share what they're doing and to help moderate our discussion today, and I'll let each of them kind of introduce themselves more fully when we get. We're going to start by just doing a short presentation for each just to see what we're all doing at our respective programs, and then we'll move into some discussion. So without further ado, I'm going to hand the ball over to Lee to talk about what's going on in Seattle.
Sounds great. Well, good morning or afternoon. Greetings from sunny Seattle. Sunny is definitely a state of mind here at the end of September. So this first slide just has a high-level overview so you can understand how our program may or may not be different from yours. So Healthcare for the Homeless Network of King County, first is we're a program of public health, Seattle and King County. So we're a public entity, which in and of itself has both resources and challenges. We do serve the entire King County of Washington State, and so you can see from the slide that not only a large percentage of that is rural area, but we have around 400 sites. Those are both fixed and mobile. But approximately 70% of our work and also our telehealth activities are in the city or greater Seattle. We serve about 21,000 patients, and then we describe our service model basically in two parts or two buckets. So first is the work that we do directly ourselves at Public Health. We have 12 different clinics and a number of different strategies there. But then we have a network of 10 community contracted partners, and that's where the bulk of, I think, our innovative telehealth work is happening. And those partners range from large hospital systems to other safety net health center systems to social and human service providers. And the remainder of the slide just has some of the innovative projects that are within Healthcare for the Homeless Network of King County. So we don't have a specific standalone telehealth program or strategy, but rather the ways that we're integrating it across all our primary care and behavioral health strategies across our network. So the slide you see here first is the table on the left is all of the different strategies where we're trying to understand what are the things we need to do to both get folks into care, support them while they're there, and then follow up. So I'll just focus for this brief introduction on the ways in which we're directly engaging folks in behavioral health services in terms of seeing them directly. So the first part of where we're seeing folks, you'll see here is we're still largely seeing folks within our hospital and safety net health center system. So being seen at our downtown primary care clinic as one example, and then connecting to a specialist at a Harborview Medical Center as an example. So won't get into the weeds there, but rather recognizing that there are a lot of distance barriers and also navigating that. I won't get into the challenges, but I will just highlight briefly some of the successes and strategies, and then just pinpoint is two specific programs that I think are doing innovative work. So first is we're trying to approach this from a digital equity perspective. So a lot of my work in terms of data and evaluation is really how do we support providers and patients in accessing technology? How do we figure out the complexity of regulations? And then how do we do that from an equity perspective and recognizing that technology should be across the board. And then there are two programs that we have. First is the palliative care program of Harborview Medical Center. Really awesome program where it's a small group of social workers, nurse practitioners that are going out to encampments, streets, and shelters, and really using telehealth in a lot of cool ways to connect folks back into that broader system. And then our Families in Shelter, and that's a Seattle-based program. And then our Families in Shelter program is in the southern part of King County, and they're doing similar work. They're not able to provide telehealth in the actual shelters or streets. It's still largely in the settings that we can control. But similar one is using all the examples on the left to really elevate us how people are being connected to care. So I'll stop there for introductory remarks and turn it back to you, Michael.
Thanks so much, Lee. So we'll go ahead and turn it over to Debbie to talk about what's going on in Atlanta.
Hi, thank you, Michael. I'm Debbie Stevens. I'm a psychiatric nurse practitioner, and I've been with Mercy Care for about a little over 4 years now. Mercy Care is a federally qualified healthcare center. We were incorporated in 1985, and actually we have a long-standing commitment to the homeless, and it goes back into the 1800s. And today actually happens to be Mercy Day, where it was like our anniversary of when the first hospital was established back in Ireland. So we just have a great history in Atlanta, great commitment. It's been wonderful to be a part of this healthcare center. And so we're very patient-centered, integrated with primary medical, dental, vision, and more recently behavioral health. So behavioral health was added maybe about 6 years ago, 7 years ago. So over the last 35 years, we've really grown, and we have 6 standalone medical clinic sites and 5 mobile sites that are surrounding the Atlanta City area, so in shelters and churches and different community centers in the Atlanta area. In terms of volume, last year we saw a little over 60,000 clinic visits across all the service lines, and maybe about 12,000 unique for behavioral health. We have predominantly homeless, so 67%, and 75% are uninsured. In terms of our telemedicine program, it started shortly after the initiation of adding behavioral health to the clinic services. It was started by Dr. Liz Fry, who some of you may be familiar with. She really was a champion for telemedicine as she was developing the street medicine team. When she started the program, it was relatively small, and she was the only psychiatric provider. So it was a means to incorporate technology, but mostly to improve access, because she was the only psychiatric provider on the team as she was growing the program. And initially it was more community-based, so I believe she was actually in the churches, or even if she was in the clinic, the staff or the team that was supporting her was actually in the community. Now it's more office-based, so even though I'm off-site, I can be at the clinic or even at home, and the patients are coming to the clinic. So that's predominantly how it is now. We are using a web-based program called Pathways. It's sponsored through Georgia Partnership for Telehealth, so it's a software program that is based on the internet, so we subscribe and pay like a licensing fee every month, and then they support us with the infrastructure and also with training and updates and that sort of thing. Right now, we're only using psychiatric providers for telemedicine. However, we have started training primary care providers and the street team so that they can start using telemedicine in a variety of services within our healthcare system. We have ongoing challenges, as I'm sure many of you have. Even though we started 4 or 5 years ago, it's still relatively a small program. However, our leadership is really invested and supportive. So I'm happy to be here to join this discussion and not just share some of the things we're doing, but also learn from many of you.
Okay, thank you so much, Debbie. So next, let's jump down, staying in the South for a bit, to Greenville, South Carolina.
Awesome. Thank you, Michael. Really appreciate being able to participate in this webinar today. So myself and my colleague here, we're going to kind of tag team this introduction part. I'll start with myself. I'm Brandon Cook. Obviously, we're with New Horizon Health Services. We are based out of Greenville, South Carolina, and we have a host of services. Obviously, first and foremost, we are an FQHC. We've been serving for over 26 years. We provide medical, dental, behavioral health services to more than 26,000 patients annually, with over 100,000 encounters, specifically for healthcare for the homeless, which has been a part of the health center now for about 15 years. We see roughly a little over 2,000 patients experiencing homelessness annually over a 13-county service area. We also have a Ryan White Part C and B program that sees roughly about 1,200 patients a year over a 10-county service area. And so really, before I pass it off to Jennifer, I'll just say really quickly, we tried to launch into telehealth just really to expand services. And with that, I'll leave it over to Jennifer.
Thank you. My name is Jennifer Schmucker. I'm the Behavioral Health Director here at New Horizon. So like Brandon was saying, obviously we have a lot of services and provide care to a lot of patients. Our behavioral health is integrated with primary care. So that's kind of part of the deal. So our telehealth really, we're kind of the infants, I think, on the panel today. We've really started as a pilot program to expand the reach of healthcare for the homeless and behavioral health, and then to increase the access to behavioral health services for people experiencing homelessness. And so really, you know, our timeline was rather short, but we were able to get it up and running. We partnered with one shelter in our service area to provide much needed behavioral health services. That shelter was actually in a very rural area, and that their the access access was only really to the local mental health center, and there were definitely reasons why, shortage of staff there, access for, our patients to be seen there. So that was why we chose that site. And also that shelter already, I guess they already had the idea that they would want to try something like this. So they were willing to engage with us to pilot.
Great, thanks, Phil. And last but not least, let's turn it over to Andy in DC.
Great, thank you very much, everyone, for joining us and for the invitation to be here today. So I'm Andy Roby. I'm a family physician and Chief Medical Information Officer at Unity Healthcare in Washington, D.C. So we're a large FQHC here in the district. Unity actually started as healthcare for the homeless in D.C. Somewhere around 40 years ago, and then was asked to assume operation of a few clinics when the D.C. General Hospital closed, and became Unity at that point, and has kind of grown from there. We currently care for about 100,000 unique patients a year, conducting about 500,000 patient visits annually. We provide primary medical, specialty medical, behavioral health, and dental services in 9 community health centers. We have 11 medical sites in homeless shelters and day centers. We also have a medical respite facility and a street outreach team. We do have 2 school-based health centers, and then also provide all the medical care in the D.C. Department of Corrections or the D.C. Jail. We are a teaching health center, so we have a community medical school campus affiliated with A.T. Still University here, and also a family medicine residency. I'm affiliated with the Wright Center, so a lot going on here at Unity. So we've been doing telemedicine at Unity for about 3 years now, I think. Our first, and we have kind of 2 primary projects that we're working on. Our first one started about 3 years ago. It involves telemedicine access to medical specialty care. So that's a research collaboration with George Washington University. Their Department of Emergency Medicine is kind of a national leader in telemedicine. They actually have a command center that does mostly maritime and kind of remote outpost telemedicine, and have done that for a long time, but a few years ago started to get interested in how they could provide, use telemedicine to really provide services to the DC community. And so we have a partnership at one of our community health centers where we offer endocrinology, nephrology, and cardiology televisits with GW specialists with the goals of improving access for our patients, decreasing no-shows to those specialty visits, kind of by reducing transportation needs and things like that, and then also improving clinical outcomes. More recently, thanks to a grant from our state Medicaid office, we have started to provide telepsychiatry services. So we have a Unity Psych NP who works for Unity, who's based at one of our busier community health centers and sees patients in person there, but then provides psychiatry consults at 2 of our shelter-based sites. So the goal there is to increase access to behavioral health care, specifically psychiatry, and also improve utilization of that provider's time. And I think, just to mention, I think the future of telemedicine, or the kind of the next telemedicine project we're looking at that I would love to hear some discussion on, is providing telemedicine access to buprenorphine treatment for some of our homeless outreach sites. So I wonder if anybody has experience there.
And thank you all for telling us a bit about your programs and your ventures into telehealth so far. The rest of today is really going to be some discussion around the challenges and opportunities that telehealth, and specifically telebehavioral health, brings in the context of healthcare for the homeless. Just so you know, I've got some prepared questions that I hope that we'll get address all of them. But this is also your opportunity to interact with each other in the chat box and ask questions of the panelists. So really, just to get us going, and please go ahead and start typing your questions into the Q&A. I want to, you've all pretty much addressed why you wanted to do telehealth, and that's to expand services. That makes a lot of sense. So now let's get into the nitty-gritty. What was hard about it? What was the biggest challenge in getting these services started initially? So I guess I will ask Lee to go first.
Sure. So what were the challenges in getting started? Yeah, I think some of the ones that perhaps are not as obvious in terms of the big bucket ones around regulations and resources and finance was what I think might be a motivational one, or a perception that folks experiencing homelessness either A, won't do it or won't be interested in that. And so I think that was both from our some just from an operational perspective. So really digging in terms of that sense of, well, is it really worth the resources if we think folks won't use it or will be suspect? And I think what we found kind of over time is just like anyone else is we need the basic information. What is it? Where is my information going? And then some of those pieces around specific behavioral health conditions, being conscious of that. But I think unpacking, and I think we see that in a lot, is whether that's stereotypes or just this belief of folks won't be ready, willing, or able. So that would be one, is in terms of just doing that work around what I think is kind of a motivational piece. And then I think really where we're talking about where we just need to go across the board in terms of outside of our clinical settings to reach folks that are most disconnected, we're still not really able to control those sites in the ways that you need to for telehealth. So our shelters, in terms of truly being able to provide telehealth directly in our shelters or on our mobile medical van. So just that next step is in terms of the challenges of increasing it in clinical settings is great, and then how do we do that next stage around outside of our clinical settings?
Great, thank you, Lee. So some stereotypes that would have to be overcome was certainly one thing. Will it be used? And you also mentioned some concerns about privacy. How is the information shared, kept confidential, I'm guessing? Debbie, do you want to speak more about, so I know that you weren't necessarily around when things got started, but if you can share anything about initial challenges.
Yeah, I wasn't really part of the initial effort to start the program, but because we're still relatively small, I feel like we're still having some challenges to really scale the program, to really build and expand the service. So I am sort of familiar with that, the challenge of actually doing that while being engaged in the primary job of providing care to the patients. Like I've been designated as a telemedicine champion, but I'm still seeing patients every day because I'm the one primarily doing it. So I think one of our biggest challenges is really developing the strategy and expanding it beyond just one or two people to really build a program. Some of the ways that we started to address that is sending me to trainings and participating in calls like this so that we can continue to learn from other experts across the country, and then really trying to build up our personnel too so that I can have some dedicated time to work with a team of people to start thinking of ways that we can expand the service and grow it from where we are right now.
Great. South Carolina?
Yeah, so to Lee and Dr. Stevens, ditto. No. But really, I feel like a lot of our issue in starting out was logistics. So with Jennifer and I partnering in order to facilitate this, part of the issue was she's in one city that's in our service area. I'm in another city. We're having to coordinate our schedules, and then the distance between my office and the actual shelter was also a challenge. So a little bit of some logistical issue there. Obviously, the shelter staff, where we piloted this program, they were super happy to accommodate us any way they could. So that was helpful. However, we still have to kind of, when we're on shelter site, another challenge was getting patients to stay engaged with the program. And what I mean by that is, because I was kind of like what Lee was saying, will they accept the technology? Will this be like too different? That wasn't the case. The issue became some of the folks weren't following the shelter rules, and so when that happens, you guys know as well as I do, sometimes the shelter will ask folks to leave. And so if that process happens in the middle of treatment, that could create some other challenges. And again, really the biggest thing really is just timing, distance, and then I would also say we had, with the equipment that we were using, we did have some initial connectivity issues, and since Jennifer is Director of Behavioral Health and I am the Healthcare for the Homeless Program Manager, and we don't list IT in any of our job titles, it took us a second to figure out exactly what the problem was, but once we figured it out, things ran a little bit more smoothly. So those are just some of the challenges that we faced.
And I would add to that, similar to what the others have shared, is that, you know, I'm the clinician that was providing the services for the patients that were identified, and so the same type of thing is, we didn't have, or still don't have, one dedicated provider or even a part-time provider. I mean, ideally, I would love to see expansion so that we could do that, but there was a lot of kind of just coordinating and scheduling. I think, too, if I can get into a little bit about the patients that we saw as far as being kind of complex and complicated, because that definitely affected. They were all actually really excited to be on camera, so to speak. So that part really was easy to engage. I think that they were all pretty fascinated that they got to participate, while being in the shelter. Like, oh wow, and I can get my mental health right here. So that part was, I think, kind of an awesome piece of it. Was that Brandon mentioned is, a few of our patients that we started working with, probably they needed either more medication management or other services to kind of help them stabilize. And so we lost, I think, 2 of our folks because they ended up being dismissed from the shelter, And so, as a clinician, that's just tough because I always want to kind of see if we can have, any type of continuity of care. And one of our guests hadn't signed the release of information, so we couldn't share, I couldn't really access, what ended up happening. So that was kind of all, in the beginning, I think that was part of it too, is in the beginning, it took a few hours per patient to really do some of the things that are required for us, for probably all of the centers, getting a consent for treatment, explaining that to them. When a person's in the office, you can hand it to them or read it to them and sit down and have them look at it, and this, one of our patients, she wasn't able to read because of a brain injury, and so Brandon, sat and explained it to her and read it to her while I was on the monitor, if that makes sense. And so even before we started the assessment, it was like to get, some of the paperwork stuff out of the way, and we used the PHQ-9, for depression and the GAD-7 for an inventory. And again, it was like, do I want to spend time asking them directly, or do I want to have staff give them the paperwork? And so I think it was, there was just kind of a lot of details that initially, you don't really think about until you're sitting with a patient, especially in my role. So, yeah, thank you.
Yeah, thank you. We've gotten several questions in, but I want to just ask Andy to address the question about startup challenges.
Sure, thank you. So, I think the things that I thought were going to be challenging ended up not being that challenging. So I was concerned when we started doing telemedicine about getting buy-in from leadership, getting buy-in from patients, and then, of course, the technology is sort of the big new thing. And, leadership buy-in came pretty naturally. Patients have been, in our program at least, really surprisingly receptive to telemedicine as an option. And the technology is pretty simple. We all use Skype and FaceTime and things like that, and it's not that much different than, this webinar that we're doing here. The thing, just to echo what some of the other folks have said that have been really hard, are the logistical things. Coordinating schedules and clinic flow and things between folks who are at geographically distant sites has been hard. So, how do you get in touch with the originating site or at the distant site when the patient doesn't come on time to their visit, or there's a delay in check-in, those sorts of things. Telephones at health centers are sort of historically not answer very consistently. So the sort of simple technology was much more challenging than the computer technology. And so those logistical things I think have been the biggest thing. And then, also telemedicine is really labor intensive. It's, for our specialty visits, we use an MA as a telepresenter. That medical assistant is often in the room with the patient for the duration of the visit because there's physical exam they need to conduct. Sometimes they need to, physician the patient, just different things like that for the specialist. And so an MA who might normally spend, 10 minutes doing an intake for a patient, and then the provider spends the rest of the time with that patient conducting a visit, that person's really tied up for a telemedicine visit for quite a long time. Hasn't been as significant for our telepsych visits. Typically the MA excuses herself for that visit. It's, usually sort of more sensitive material being covered and things like that, and so often it's just the provider and the patient who are in the visit together. But somebody needs to be available in the event that a technological issue arises, or there's a crisis that needs to be addressed, or something else comes up, and so you do need somebody sort of within earshot all the time. That's been a challenge.
Thank you all. Well, we have gotten several questions, and I'm not going to get these in order because of the way that this technology displays them on my screen. So telehealth problems. But I want to, let's just start with Jesse's question from Boston. Hi, Jesse. So the question is, how do you most efficiently set aside behavioral health clinicians' time to provide telehealth services to people being seen on a mobile unit? We don't know when patients will be available for televisit, so it's hard to figure out how much time to set aside for the clinician. Anybody? I know that Brandon uses the the mobile unit. Do you want to address that piece?
Sure. So that's something that Jennifer, as the Director of Behavioral Health, and I have discussed many times, because I think my staff love to have a behavioral health clinician on site, but I think that was another reason why we kind of went in the direction of telehealth, because we couldn't account for when patients will show up at a shelter. We have the benefit of when we're scheduled to go to a shelter, a lot of times we'll have a decent, plan or a decent list of patients that we're expecting to see. But like I said, we're expecting to see, so folks have other priorities even though they know the doctor is coming. So I'll say all that to say, we thought telehealth would be a way to kind of work around that, because in working with Jennifer, we were able to get patients physically on her schedule, so it worked like a referral. The primary care provider would identify a need, refer that to Jennifer. Jennifer would get that on her schedule, and then I would physically go to the patient and set up our telehealth, and then Jennifer had dedicated time for that specific patient. So that was one way that we're kind of addressing it. So we weren't able to address it real time in the moment, just because we just don't have that kind of staffing to kind of have someone dedicated. Jennifer.
Right. I was going to say, and to add that, here in the clinic, we do our clinicians do a lot of like brief interventions, which I feel like would make sense in the context of, persons experiencing homelessness. So, again, like ideally I would love to block out, half a day to just be available for when, the unit is out or deployed with the mobile unit. But I mean, that's not something we've been able to really do yet. And because, of course, like with funding, how we're going to account for that time. But I certainly am hopeful and optimistic that at some point, we'll be able to make that happen, where it would be more of like, clinician is available kind of with the unit, for more of that kind of as needed, almost, crisis intervention type of stuff.
Right. And Lee, does your program use the mobile medical unit too?
We do. So, but we do have chemical dependency professionals and social workers in the van already integrated on that. But I think we're struggling with the same types of issues in the sense of if we're thinking about the need for crisis intervention, referrals, connections to psychiatry, we don't have that. So we always have had behavioral health folks always integrated into the van since the beginning. But being able to provide telehealth in the ways that we're describing, we're not there yet.
Let's talk about like the staffing at the shelters if you're seeing patients there. The question is, if providing telehealth services in a shelter setting, what is the staffing on site at the shelter? Who assists the patient with the technology? Does anybody want to jump in on that one?
So, Michael, I'm happy to kind of start this conversation. So we kind of have to, for our purposes, we look at this a couple of different ways. So one, when our mobile medical unit goes out, it goes out with the full cadre of staff, right? Obviously, there's a provider, there's a clinical support staff. So when Jennifer and I were doing the pilot project, we really kind of figured out early on that really all we need is the clinician, which was Jennifer, and then someone just to really, again, in the beginning, this is what we thought, someone just to set up the telehealth device, turn it on, make sure it's positioned correctly, and then leave. But we quickly found out that you can't go far because there are connectivity issues. There are things we didn't account for, as Jennifer explained earlier. We didn't account for people with literacy issues, right? So being on standby to be able to facilitate that. But for us, when we did it, it was easy enough just to have a provider in the office on the screen, and then one person, in this case an administrator, I know, which is super overkill, but yes, an administrator to kind of help facilitate the telehealth process as far as setup. So that's kind of how we did it.
Anybody else want to address that point about shelter staff? So I think this next question is interesting. What protocols or guidance have you developed for evaluating whether a patient should be, I guess, evaluated in person rather than remotely? Are there instances where you're like, this isn't going to work remotely, I need to see this patient in person? Anybody?
So I don't know that we have any particular protocols. We typically have left that to kind of the provider's discretion, and haven't actually had any cases at this point where the provider wasn't comfortable providing all the services they needed to provide via telemedicine. So may not be the best person to answer, but haven't encountered that.
Sure. I'll add the.
I was just okay. Go ahead. You want to go ahead?
Okay. Thank you. Just that when we were, we initially set it up so that we would do a face-to-face with the shelter director, and we didn't have, I don't think we really developed a written process or protocol, but we had the conversation, and staff understood, because I was concerned that, if an individual with, let's say, like post-traumatic stress disorder or something, if it comes up, that we want to make sure that we're getting them to the emergency department or whatever needed to happen to make sure that they were okay. So we did kind of talk about that there needed to be an appropriate staff person at the shelter that would be able to arrange for the person to be seen if they needed to go, let's say they were in a serious crisis. So I forget kind of the original question, but just, did we develop a process? I mean, we knew what we needed to do, as far as if during a session, a person wasn't able to de-escalate or calm down, that's kind of why having like Brandon nearby and staff, but that I could I would even send a text, because I can put, I can send a text and say, what, just come back this way because, come back towards the door in case I need you, and so with when we were setting up the space in the shelter, the director again, graciously gave up his space, his office area, because he knew that it would be kind of more secure and confidential. I think we had to put paper over the window portion, for confidentiality, and make sure that other guests weren't going to try to come in and bust in the room. You know what I mean? So the same thing that we would do sort of like in any other setting or on the unit. You know what I mean? You make sure a person has their space to work.
Yeah, and really quick, because I know Dr. Stevens wanted to jump in, but really quick, Jennifer's brought up a really good point. about being able to text, and that's something that we did talk about beforehand, because we understood if someone is outside of the door and can't see exactly what's going on and may not be able to hear what's going on, and the patient was in the middle of a crisis or an episode, we wanted to develop something to where Jennifer or the clinician could alert some staff as to, hey, this is really becoming, I need you to secretly dial 911 or something like that. So we really were very intentional about that, and I'll be quiet and let Dr. Stevens talk.
Okay, or just to say too that, you know, or to even let everybody know outside of the room, like, things are okay. You know what I mean? Like, you know, patient crying is like, or, you know, it's not a crisis, because sometimes there's confusion about if there is, you know, if this is immediate need or not. So, all right, thank you, Dr. Stevens.
No, I was just going to say, like, I agree with Dr. Roby, like, there are just very few clients who I've found that were inappropriate for telemedicine. I think with the support team and staff that I've been able to see just about anyone. But I did think of an example where I had a hearing impaired client, and so he had like 2 or 3 interpreters, like a hearing interpreter and then a deaf interpreter, and it was just a lot. And so I just had to make sure that I'm always communicating with staff and whoever's scheduling that there are, you know, clients that would benefit from a live face-to-face, and someone that has those type of disabilities would fit that criteria. So I just want to throw that
out. We've had a few questions sort of making the distinction between actually conducting like therapy versus psychiatric treatment. So is it primarily prescriptions that we're using telehealth to arrive at, or are we actually providing like consulting? Like, are we doing therapy in the session? And if so, how long are those sessions? So actually, Jennifer, I know you're a social worker, and we've got a psychiatric nurse practitioner and then a physician here too. So does anybody want to address that piece? Or Lee, on behalf of your providers and staff.
Well, right now I'm primarily the main one using it, and so I'm doing psychiatric evaluations and medication management only. So I'm not, I mean, I may provide some supportive therapy in those sessions, but it's not primarily for therapy. We are looking at ways to expand it for our behavioral health specialists, so LCSWs and other therapists, to potentially start using it, but right now it's for the purpose of medication management and provided prescriptions.
Yeah, we are also doing primarily med management, you know, in our telepsych visits, and again, it's a psych NP that's conducting those visits. You know, we've talked in, you know, various times about therapy via telemedicine, and that was something that people were, you know, a lot more uncomfortable with than psychiatry visits, just because, you know, a lot of our providers felt like you needed, you know, you know, in-person, sort of more personal approach to therapy. That being said, I actually seems like there's more teletherapy being done than telepsych in a lot of programs, so that may be our own kind of bias. And, you know, historically it's been a lot easier for us to hire therapists than to hire psychiatrists or psych NPs, and so you know, we have therapists at almost all of our sites, but it's been harder to get psychiatrists or NPs to staff sites, so telemedicine, you know, better utilized as well.
Anybody else want to weigh in?
I would say, obviously, I'm speaking from a therapy perspective, you know, and part of the way that, and I'm not sure about all of the other programs or centers, but, you know, our primary care providers do a lot of the med management because of the psychiatric limitations, you know, and so patients that we're seeing, or that I was seeing, was obviously primarily for individual therapy, but then because we worked already with the provider who would be coming on the mobile unit to the shelter, if that makes sense, they were able to manage meds, you know, which is why, you know, I think that one of the patients that was dismissed, I think, you know, probably needed more, but we just couldn't make that connection happen at that time. So.
Anybody else on that beat? So I don't know how much this will be applicable to everybody since there are state level differences, but I want to address this question that says, here in Wisconsin we struggled with access to telehealth for Medicaid members. The biggest issue arises with medication prescriptions since many of the providers on the platforms available are not Wisconsin Medicaid certified. Does anyone experience this or care to share what their states are doing to ensure callers that need prescription interventions receive the care they need? So any of these troubles with out-of-state providers?
The question is, so in Wisconsin that they're dealing with folks that are out of Wisconsin? Just clarify the question.
Yeah, that's what it appears to be. Many of the providers on the platforms are not Wisconsin Medicaid certified, so I guess that means that they're not in Wisconsin. That, yeah, like I said, it may not be.
We don't have that specific experience in terms of Oregon or our surrounding states. I couldn't comment there.
Okay. So are any of your programs providing telehealth services in unsheltered locations, encampments? I know that Debbie said that Liz Fry started, who was the street medicine provider. Are any of your programs still doing that? And if so, can you address sort of the unique challenges there?
Yeah, right now we're not. We've kind of moved to more clinic-based. However, we still have an active street medicine team. We're just kind of staffing-wise, we don't have a full-time psychiatrist on that team, but we are looking at using telepsych with the street medicine team. So yeah, so essentially, the provider will probably be out in the clinic or off-site or at home, and then the team would have an MA. Like I have the luxury of having a psychiatric nurse actually working up the patient with me, so that really helps in terms of the robustness of the assessment. And so it would probably work similar as, if the person was in the shelter or in the clinic, if you have the right support team to be able to, assess the patient on a patient end.
So I'm going to take a break from the questions that are coming in through because I want to make sure that all the different panelists have the opportunity to move beyond some of the challenges that we've talked about already, and there have been several that have been mentioned, some of which we anticipated were challenges before we got started and ended up not being that big of a challenge. And so let's talk now about some of the solutions and your experience to overcome a lot of these challenges. And then maybe just say a few words sort of in closing about where you want to go next and where do you perceive additional challenges in the future. And so I'd love to come back to Lee in Seattle to talk more just about the solutions going forward.
So solutions and strategies. So probably a few that I think have been talked about at a program or individual level is really identifying who are the champions and then where we're seeing success. So I mentioned our mobile palliative care and our families in shelter, where we can start to see, essentially, I think when we're talking about on the front line, if folks have an example of, a program like me was able to figure this out in specific kind of resources. So that would be one. It's just at an individual and institutional level is kind of demystifying what telehealth is for behavioral health purposes and identifying specific providers and individual champions to connect. And at an institutional level, for us, that similar to the question from Wisconsin, is reimbursement for some services is still a challenge. So Washington was able to pass legislation that is still slow going, but trying to advocate for reimbursement. And similar to that, I think that there's some moves with the HRSA reporting to start to track virtual visits is to be able to really not only get reimbursements, but start to get credit, if you will, for that. So those would probably be the two off the top, is identifying individual programs that are a little bit ahead and kind of can demystify it and start to answer some of the nuts and bolts questions. And then conversely is kind of working at a policy or systems level to try to get reimbursements in reporting.
Andy, you want to pick it up?
Sure. I mean, I think I actually will echo a lot of what Lee said. I think the most critical thing for us has been kind of a champion at each site, at the originating site and the distant site. Really, I talked about kind of coordination and logistics being the most difficult part, but once you have somebody who's invested in the program and kind of believes in telemedicine and is willing to take responsibility for it at each site, and the person at one site is talking to the person at the other site, things actually go pretty smoothly. So it did take time to identify those people, and we've had some staff turnover that's been made it necessary to re-identify the person. That's been a bit of a challenge, but once people are on board, it becomes much easier. And then the other thing is when you're we started really small, and when you're only doing a visit or two a week, I'm kind of piloting and getting used to it. It's not part of people's workflow, and it's pretty hard to get into a flow, but once the volume picked up, it also got a lot easier.
Go to Debbie next.
And I would just add, once you identify that person, like make sure they have support and dedicated time, because as that person, if I'm still seeing, a full schedule of patients every day, sometimes it's hard to have dedicated time where I can be really intentional to grow and develop a strategy plan and get the support that I need. I feel like at a organizational level, like they made it part of their strategic initiatives and their goals, but again, having that support team and growing the team beyond one person is also really important too.
Brandon.
So yeah, for us, even though it was a pretty small pilot program, I do think we had some pretty good successes. Obviously, the patients that we had go to completion. The shelter staff who have been working with these individuals with medium to moderate success, they were able to show a marked improvement in the individual's mental health status, to the point to where one patient in particular was able to not only complete her treatment, but also, I believe, reconnect with her family, get out of the shelter, and get into a much better position in life. We had bought some really fancy equipment, so that afforded us an opportunity to really test out the equipment, really learn what kind of technology we need to make sure that we have consistent connectivity. We also increased the buy-in that we got from our senior leadership, as well as our board to some degree. It was really starting to bubble up in some of the board meetings as well. And then just a lot of opportunities for expansion, right? It definitely opened up the door for more conversations to be had for expanding the tele-behavioral health portion of this, but also starting to have more conversations about telehealth for primary care. We've even had conversations about how to implement telehealth services into our brand new respite program, so excited about that. In terms of strategies, we still need to work on getting more buy-in from some of the other provider teams within the organization. We continue to build our community partnerships. We're about to sign an agreement with the Youth Drop-In Center to provide some telehealth services for them. And again, tele-behavioral health has also come up in that conversation as well, and also an opportunity to work with the local mental health department. And then probably the biggest strategy is really just nailing down and understanding our own state laws and regulations around billing. When we started this, my selling point was the way our program is set up. I basically said if we use tele-behavioral health to see healthcare for the homeless patients, then I will pay for it. So we're not having to reimburse through insurance or anything like that. And again, my partner here, Jennifer, was awesome. It didn't take too much convincing once I kind of laid out the plan, and it was a good opportunity for us to kind of test drive this and see where we really wanted to go with things.
Oh, I would say I'll just add, I mean, Brandon pretty much covered most of it. Obviously as a true clinician, I'm going to say that, having, a handful of patients or one patient, be seen or be served, get treatment or access to treatment is an important part of what we do, why we're in community health. So again, I would definitely, I know I'm excited about some of our partnerships and the Youth Drop-In Center, and even in our own medical respite program, we have talked about, providing that service through telemedicine, through telebehavioral health. And so, I mean, there's so many opportunities, I would say, but I feel like if one or two people has helped, like they were for us, then I feel like it's worth it, because it definitely grows, like it's already been said. You can see that need. So, thank you.
And just quickly before we start to wrap up, a question about, and I think Andy was starting to get to this, about the opportunities for MAT.
Hello?
Oh.
Can you hear me?
Hi.
Oh my gosh,
I can,
you
but I
can't hear
don't
me.
know how you have access to
Hello?
the phone.
Hello?
Sorry, I don't.
Hello?
This is a telehealth challenge. We are about to wrap up, but I wanted to ask Andy to expand on MAT opportunity, assessment and prescribing versus telehealth that you'd alluded to a second ago.
So so at Unity we have been growing our MAT program for the past couple years, thanks largely to some grant funding from our Department of Health. We've got about 20 waivered providers now, offering services in most of our health centers, really aiming for kind of walk-in, same-day access to treatment for folks. The place where we haven't done as well at offering MAT services is in our homeless sites. So I run a clinic at one of our larger shelter-based sites, but often either haven't had waivered providers or haven't had waivered providers who are sort of comfortable providing MAT at some of the smaller sites. And so this is still kind of in its infancy, and we haven't actually done any visits yet, but our idea is to have the technology available to do telemedicine visits with a waivered provider at some of our smaller shelter-based sites, and even have our street outreach team have access to that. So we are actually need to sign off on the budget to purchase some iPads to provide for at the sites where the patients are at. And then I am actually personally doing just MAT right now, and so have a clinic that's a little slow, and so I think we'll start by having me available during that kind of slow clinic for the sites where they're providing primary care, and see where it goes. The way the law works as regards MAT right now is you can't do I couldn't do an initial MAT evaluation sort of on my own for a patient. However, if one of my colleagues who is not a waivered provider does an evaluation, diagnoses the patient with opioid dependence, and then determines that they may benefit from buprenorphine or some other sort of MAT, I can then do an initial telemedicine visit and actually write an initial prescription for that patient, as long as they've actually had an in-person evaluation with another provider who's then handed them off to me.
So before we wrap up, I just want to ask if any of the panelists have one burning word of advice that you want to share with everyone before we say thank you and move on.
I will just say, don't give up.
Right.
Yeah, I know it's tough and I know it's frustrating. The changes in the laws they're slow, but they are starting to change. They are happening. Don't give up. This is great, especially if you're a program that is in that has a lot of rural areas in your catchment area. I mean, telehealth is in my opinion, such a great way to expand services, expand your reach, meet more people experiencing homelessness in intentional and meaningful ways. So that's my soapbox, and I'll stop.
Great.
I would ditto
Well,
that as well. I think starting small.
Go ahead.
Ditto.
Start small, good. Well, I just want to thank all of our presenters today. What a wealth of information and diversity of experiences, and thank you to everybody who participated in the chat box. I know we didn't get to all of your questions today, but again, this is being recorded and will be put on our website by the week of October 7th. When we close the webinar, an evaluation will automatically open in your browser. Please complete it so that we know what to do better. And we just want to thank everybody for their time. Again, thank you for the panelists. And we will continue this conversation on a national level. Come to our conference, submit an abstract to our conference in 2020, and stay in touch with us, and we'll keep this conversation going. So thank you again.